So let's get right to it. My name is Robert Redwood. I go by Bobby. I'm a full-time emergency physician with no conflicts of interest to report. We're going to talk about what sepsis downcoding and claims denial is, why it's happening, and what clinicians can do. We're caught in the middle of two worlds. CMS is telling us to do the sepsis score measure. The payers are telling us these patients aren't septic. We're not going to pay for it. What do you do on the floor with the patient in front of you? Now, the sepsis definition has been changing, right? We went from sepsis 1 to briefly sepsis 2, then to sepsis 3. And we're not going to get way into it. The chart's here for your reference. But sepsis 1 was based on SIRS criteria and a source of infection. Sepsis 3 is based on a dysregulated host response to infection or a Q-SOFA score greater than 2. These are two very different things. Sepsis 1 was designed to screen patients for systemic inflammatory response that could be sepsis and progress to septic shock. SEP-3, or the Q-SOFA score, is designed to sort patients into ICU needs, which patients are requiring that critical care resources. They're both very useful definitions. They're both used for very different things. There is absolutely a debate among physicians about which is right. When should we be using sepsis 1? When should we be using sepsis 3? Some have even advocated for using different definitions depending on your clinical environment, whether you're in the ED sorting patients or whether you're in the ICU treating critical illness and allocating resources. Now, anytime there's a controversy in medicine, the payors is with an O, so these aren't your patients paying bills, but rather insurance companies who are allocating funds through DRGs. The payors will find any discrepancy in medicine and usually try to pay to the higher standard, not the lower standard, thus saving their shareholders money. So they have picked up on sepsis 1 versus sepsis 3. And let me give you an example. If we had a 65-year-old male patient with pyelonephritis who had a white blood cell count of 23,000, a temperature of 104, and a lactate of 5, in 2015, this patient would have been septic, probably severe sepsis. In 2017, by SEP-3 criteria or Q-SOFA score, this patient might not be septic at all, depending on other lab values. And so you could see how someone looking at a claim could say, well, it's 2019, we're using sepsis 3, this patient is no longer septic, and we are not going to compensate you or your hospital for your critical care resources. Now, I don't think that's right. We're expending a lot of critical care resources on this patient to bend the curve, to avoid that progression to septic shock. But semantics can be a big thing. The devil can be in the details. And so we're going to help you work in such a way that you honor the patient in front of you, but also get compensated for the work that you are doing, providing critical care resources to this critically ill population. Now, of course, ICD-10 classification and official CMS coding guidelines have not abandoned the sepsis 1 definition. In fact, we're being asked to use that definition on a daily basis. But some payers are issuing DRG denials for sepsis claims, saying, hey, there's no Q-SOFA score greater than 2. Hey, you haven't documented a dysregulated host response to infection. This patient isn't septic. What are we to do on the floor, in the ED, in the ICU, with patients in front of us? For patient care, I say don't get hung up on semantics. We know what we're talking about. We're talking about a patient who has the potential to become bacteremic, the potential to have a dysregulated host response to infection, the potential to have organ damage. That is sepsis. Whether you want to call it sepsis 1 or sepsis 3, we know the clinical identity in front of us. If you are a nomenclature person and it is really bugging you, I would think of SIRS and sepsis 1 as still useful. I wouldn't throw them to the curbside. Just think of them as high risk for progression to sepsis. If you think of SIRS and sepsis 1 in that fashion, these two definitions can actually coexist. And then I would recommend that you treat per CMS core measure recommendations. Now, we have many YouTube videos on the core measure. I'm not going to get deep into those specifications, but I would recommend that we screen patients for sepsis in the emergency department based on SIRS criteria. And then if they do have more than 2 SIRS criteria and a nidus for infection, we treat them with blood cultures, broad spectrum antibiotics, 30 cc's per kilogram normal saline, and initial lactate with a repeat in 2 hours if greater than 2. Now here for billing purposes, there's a little bit of nuance here. Sepsis 3 is or will be the standard. I think that much is clear. And the payers are really good at changing the standards of medicine. They're actually good at influencing the conversation by making it appear that the conversation is closed when in the physician community it may not yet be closed. That being said, if you have a patient in front of you who has any signs of a dysregulated host response to infection, those special words should be written in your chart. So if your patient has sepsis with chest pain, if your patient has sepsis with altered mental status, if your patient has sepsis with decreased urine output, they have a dysregulated host response to infection, and it would behoove you to mention that in your chart. Now, you also want to document infection and evidence of organ dysfunction if it is present. So any patient who is hypotensive, that is organ dysfunction. Any patient who has acute renal injury or renal failure, that is organ dysfunction. Any patient who is encephalopathic, that is organ dysfunction. If you are a coder coding for your emergency department, it would be very helpful for we as physicians or APPs to actually jot down the dysregulated host response to infection and the organ dysfunction. And if you really want to get a gold star from your coders, you can include a QSOFA score. Again, we should never be dishonest in charts. We should chart everything accurately. But I think a lot of the time we could go the extra mile and describe the septic patient in front of us in more detail so that it's clear that they also meet Sepsis 3 criteria. Now, what if you're with hospital administration? What if you're with the quality department? How are you going to play defense against downcoding? And you do have to play defense these days. This is the game of medical billing. Well, we know that insurers aren't reviewing every single chart with a fine-tooth comb. They do not have the workforce for that. That would be very unrealistic. What they are doing is auditing certain charts. So they are pulling choice charts that are high risk for potential to be downcoded. What are they looking for? They're looking for hospital stays less than 2 days. There's no way this patient could have been septic if they only stayed in the hospital 2 days. I'm being facetious. They're looking for sepsis that's only mentioned in the final diagnosis. DKA, 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 final diagnosis, sepsis. That's a red flag that insurers or payers are going to pick up on. And then they're looking for competing diagnoses. This patient had an allergic reaction and they were also septic. Let's dig into that. Let's see if that sepsis can be downcoded to another clinical entity. So we already know which charts are being flagged by the payers. We can actually flag these charts ourselves. So if you're a quality professional in your hospital, you can audit this cohort of charts and review them yourselves before you send them off to the payers to see if the physicians can tighten up their charts, to see if there's any discrepancies, and then you can actually use the information that you garner there to advise your clinicians on how to better code or chart in the future. Finally, the core measure sepsis definition. Is it up to date? That's debatable. I think it's likely that the world will eventually move to Sepsis 3. Is it useful? Absolutely. Remember, the definition of sepsis, when paired with lactate, is actually going to tell you which patients in your department are sick. That's what I want to know. On a clinic basis, I want to know who are the sickest patients in my ED, who is requiring clinical care resources. If you meet Sepsis 1 criteria with a lactate greater than 4, that's a 30% chance of in-hospital mortality. If you meet Sepsis 1 criteria and low blood pressure with a lactate greater than 4, and low blood pressure, that is a 36.7 chance of in-hospital mortality. And finally, if the patient has low blood pressure, Sepsis 1 criteria, and a lactate greater than 4, that is a 46% chance of dying in the hospital. This is a very useful set of criteria. It's very useful for us as clinicians to spring into action, to spring into critical care mode, and start treating the patient in front of us. And I think you'll find more often than not, based on clinical gestalt, that your septic patients meeting Sepsis 1 criteria are also in some form or another meeting Sepsis 3 criteria. We just have to be crystal clear in our documentation so that we get compensated for the work that we're doing and honor the patients in front of us by still treating them with those critical care resources that they deserve. I have a question slide. This is obviously pre-recorded, but we always address questions in the comment bar or in future videos. So feel free to leave your questions and we'll address them as we can. Thank you, and good luck on your next shift.